Okay, so the first thing I want you to do, we're going to start with increased pulmonary blood flow. These are the defects that cause increased pulmonary blood flow. For each one of these congenital heart defects, I want you to first of all look up the definitions of the words in the name. If you understand the words in the name, then it's going to help you remember. So if I say the words atrial septal defect, I want you to understand that this has to do with the atria. Okay, there are two atria. There's the right atrium and left atrium. And there's a wall between them, the septum, sorry. Okay, atrial septal defect. That means there's a hole in the wall between the two atria. So the first thing with each one of these is make sure you understand the name, because almost all of these, if you know what the words in the name means, the words in the name mean they're going to, that's going to help you understand the physiology. So the next thing is to make sure you understand the patho. What is actually happening with this defect? And then what happens to the blood flow? How does that defect affect the blood flow? Okay, so all of the defects in this group increase pulmonary blood flow. So for just a minute, think about what happens if we get more blood flow to the lungs than we should. Increased pulmonary blood flow. I want you to pause for just a minute. Okay. What you're going to see is fluid overload on the right side of circulation. You may see heart failure too, fluid in the lungs. So we're going to look now at these specific defects. Okay. So first of all, atrial septal defect is an opening between the atria. And the first thing I'm going to say is that this arrow is probably going the wrong way. So ignore that arrow. We have the right atrium, that's deoxygenated blood that is going out to the lungs. We have the left atrium that is oxygenated blood that is going out to the body, right? But we have an opening between the right atrium and left atrium. So usually we're going to get a little bit of blood that should be going to the left ventricle. It's instead going to go through that opening into the right atrium. So we're sending extra blood to the lungs, okay? Now, because this is in the atria, the atrial pressure is usually lower than ventricular pressure. So a lot of times this is tolerated fairly well. And this is one that someone might actually not realize they have it until they're older, okay? So what you're going to have is just very slight increased pressure in the pulmonary vessels. So later in life, the damage of that increased pressure, what does increased blood pressure do to small blood vessels? It damages them over time. So later in life, they may have damage to the blood vessels that go through the lungs, and so they can develop some pulmonary hypertension later. What does this look like? What do you think this kid is going to look like? They might have, if we've got blood that should be here going over here, the right atrium and ventricle might enlarge because it's got more blood and it's having to push harder to get it through the lungs. Okay. They might not have any symptoms at all. If they do, they may have some heart failure. They may have symptoms of heart failure. What does that look like? Well, they may have fluid in their lungs, so you might hear crackles. If they've got fluid in their lungs, they can't exchange gas as well, so their O2 sats may drop. Again, remember this is less likely than with some other defects, but they may have some CHF. They may have a murmur. They are at risk for dysrhythmias, pulmonary vascular disease, because these vessels have too much pressure, so they get damaged. Bacterial endocarditis, because blood or bacteria that's in the bloodstream will collect on places where the blood flow is kind of rough. And for the same reason, emboli. So right here, instead of when the atrium contracts, the atrium empties into the ventricle, then the ventricle contracts, empties into the aorta. if we've got an opening here, then I want you to think about fluid that's in a container and it has two different ways to go out. That's going to change. You're going to have some kind of eddy patterns. You're going to have blood just kind of swirling around and sitting sometimes. And when blood sits still, then it can clot. So there's a risk of clots. Okay. Surgical treatment for this, if this does not, this is when the foraminal valve doesn't close. So if it doesn't close and they have an atrial septal defect, it can be patched. Sometimes it's big enough that it affects a valve and they may need a valve replacement as well. Sometimes they can patch this with cardiac cath instead of doing open heart surgery. The prognosis for this is usually good. The mortality is pretty low. Okay, we're going to move now to the next one, and I'm going to stop and reshare. I want you to pause the recording, go back, make sure you have a good understanding of atrial septal defect and how it increases pulmonary blood flow. Now we're going to move on to the ventricular septal defect. Okay, just what do you write down before we look at it, what you think ventricular septal defect is? Okay, it's an opening between the ventricles that shouldn't be there. So atrium contracts, pushes blood into the left ventricle, and then we have this hole between the ventricles. This can be a pinhole or it can be the entire septum gone. Do you understand how that's going to affect the severity of manifestations? If there's just a little tiny pinhole here, when the ventricle contracts, most of the blood's still going to the aorta. Teeny tiny bit of it might go over here to the right ventricle. But if all of this is missing when the left ventricle contracts, then the blood's equally going to go to the aorta and the pulmonary artery. So it's going to really affect blood flow. Okay. So the size of the defect actually affects how severe the shunt is. Usually we're going to get a left to right shunt because more pressure on this side, there's more blood, and the left side of the heart is stronger, so it pumps harder. So usually we're going to get a left to right shunt. The right side, it's getting all this extra blood that it has to handle and push through. And so it starts to overgrow. What happens when you work muscles more, they grow more. So the right side of the heart, they develop ventricular hypertrophy. They also, remember, we're putting extra pressure through these vessels. So we're getting a lot of extra blood or more extra blood flow through the vessels than an atrial septal defect usually. Ventricular septal defect, you're going to get more extra blood that goes to the pulmonary arteries. So they're more likely to have heart failure. It's common. They have more likely to have that. They're more likely to have a murmur. And they're going to develop that pulmonary vascular disease because this extra pressure damages the vessels in the lungs. They develop that earlier because they have more pressure. Okay. Surgical treatment, the preferred treatment is complete surgical repair. If it is not possible to repair, if this baby is not stable enough to repair and there's a large defect, so we're putting a lot, every time this ventricle contracts, it's shoving a whole lot of blood over, they can do something called pulmonary banding. They can actually put a band on this artery. So what do you think that would do? If we band this artery, not we, the surgeons, I'm not doing this. That increases the pressure. So now when the left ventricle contracts, there's some pressure here, and that's going to allow more blood to go through the aorta and less of it to go to the right ventricle. That is a temporary fix that improves blood flow, but it's intended to be temporary until they're able to go in and actually repair that septum. Non-surgical treatment, they would monitor. Sometimes if it's a very tiny defect, they might monitor it. Prognosis for this, these can actually close on their own, which is why the smaller ones, they tend to monitor for a bit and make sure and see if they'll close on their own. But it's also commonly associated with other defects. And so if they have this one, they're likely to have other things going on with it. If they're symptomatic, they have to have some kind of treatment because they'll be in heart failure. The prognosis long-term depends on how severe this is and if there are other related defects. Okay, so I want you to take a few minutes, pause the recording, take a few minutes, go back and review ventricular septal defect. Draw pictures. Your little boxes on your notes at the top of each one of these defects, pretend that's a heart. Label them right ventricle, left ventricle, right atrium, left atrium. And I want you to draw arrows that show where the heart's going to go. Draw your lungs and your body out next to them, whatever helps you. But those little boxes are for you to show yourself, to help you remember where the blood's going. Okay. Next, atrioventricular canal defect. So let's look at this one. Okay. This is the most common cardiac anomaly in Down syndrome. So what happens? This is a defect that it covers the atria and the ventricles. The wall that goes between them doesn't form completely. So with ASD, you've got the wall between the atria is incomplete. With VSD, you've got the wall between the ventricles incomplete. With atrioventricular canal defect, you actually have missing wall between the atria and the ventricles. And it also means that the mitral and tricuspid valves that go between the atria and ventricles are not completely formed either. So when the atria contract, the blood goes down to both ventricles. When the ventricles contract, the blood goes out to both pulmonary artery and aorta. So there's basically a large valve in the middle of the heart, and all of the blood from all four chambers mixes. Okay. Now, the hemodynamics depend on the pressure in the heart chambers and the resistance of the pulmonary and systemic circulation. Most commonly, you're going to get a left to right shunt. Blood that should be going out to the body is getting shoved into the pulmonary artery. But if there's a lot of pressure in the lungs, it can actually reverse. And sometimes, depending on what's going on, they may go back and forth a bit. But most common, they're going to have a left to right shunt. Immediately after birth, they don't. Because remember, this pulmonary artery is, the pulmonary vessels are constricted. So immediately after birth, they don't have much left to right shunt. But once the pulmonary vessels relax, then you have more and more blood that's getting shoved over into these. Because remember, blood goes where there's less pressure. Okay. This is going to cause moderate to severe heart failure. They'll usually have a murmur that you can hear. They'll have mild cyanosis, but it's going to get worse when they cry. They're at high risk for pulmonary vascular disease because they're pushing so much blood through those pulmonary vessels. Okay. Surgical treatment. Palliative treatment is if the infant is really small and has severe symptoms and they're not stable enough to do surgery yet. Remember, they can do the pulmonary artery banding, which that's going to decrease blood flow to the lungs and increase blood flow to the rest of the body. Most commonly, sometime in infancy, they want to do the complete repair. They patch this opening between the septa, and then they reconstruct or repair the valves. Post-op complications, it's common for them to have heart block, heart failure, mitral valve regurgitation, dysrhythmias, and pulmonary hypertension. So this shows we have the septum repaired and the valves repaired. Prognosis, the mortality is a little bit higher with this one. The operative mortality is 3 to 10%. That means about 3 to 10% of those babies pass in the immediate or fairly soon after surgery. Potential late complications, they survive and they recover from the surgery. They're likely to develop mitral valve regurgitation later on. Okay, I want you again, pause the recording, take a few minutes, look back over atrioventricular canal defect. Make sure you understand what the name means. Make sure you understand what's happening with the blood flow and why it causes the complications it does. We're going to go now to patent ductus arteriosus. I bet you can guess what that means. Try to guess what that means before we go. Okay, patent ductus arteriosus. Remember the ductus arteriosus that allows blood to shunt from the right side of circulation to the left side in utero so that we don't send blood to the lungs that aren't working. That ductus should close. What if it doesn't? If the ductus arteriosus doesn't close in the first few weeks, then the aorta ends up with more pressure than the pulmonary artery because the left side of the heart is stronger. We've got more blood. Once these vessels relax, the pressure is higher on this side, and so they have a left to right shunt. Okay. This can be asymptomatic. If they have symptoms, they're going to have heart failure symptoms. Have you seen the pattern yet? If we send too much blood to the lungs, we have heart failure. Okay. So they can be asymptomatic or have heart failure. If you listen to this, you're going to hear a murmur that sounds like a machine. It's called a machinery-like murmur. You'll hear a murmur that sounds like a machine. They may have widened pulse pressure, which means a bigger gap between the systolic and diastolic blood pressure. They may have bounding pulses. Okay. There's a risk for bacterial endocarditis and pulmonary vascular obstruction. I want you to think about why. Why would they be at risk for bacterial endocarditis? Remember, right here is a place where instead of straightforward blood flow, you may get kind of swishing around or sitting still. It's a place where bacteria can grow and clots can form. And if we're pushing blood that should be going to the body into the lungs instead, or into the lung vessels instead, we can end up with damaged vessels over time. Surgical treatment, if it doesn't, non-surgical treatment first. Medically, they can give endomethacin to try to promote closure. Endomethacin is an NSAID, and it can sometimes cause this opening to close. If that doesn't work, they can use use the cath lab, do a heart cath, and use coils to close a small defect. They can also do surgical ligation. They go in and just tie it off. They used to do an open chest procedure for that. It doesn't have to be open heart, but an open chest procedure. More recently, they've been able to use to do a scope procedure, which is a lot less risky. Prognosis, surgical procedures are very low risk for treating this. This is usually easier treatment. Mortality for these babies is more often related to another type of problem, another medical issue. Okay, that's the end of this section. I want you to go back and review these and think about how is this defect putting more blood into the vessels that go to the lungs, because these are all the defects that increase pulmonary blood flow. The next section is going to be about obstructive defects.